Hello and welcome to our training on addressing implicit bias as part of the CARE Act. This is part of a series of trainings to address equitable and person-centered care within CARE Act in how we, all members of the CARE team and CARE process interact in ways that limits the impact of implicit bias on the care that we provide. I wanted to introduce a few of our speakers that will share their expertise and their background in how to manage implicit bias. We have Dr. Karen Louise Hill, who is from Health Management Health Management Associates. She is a nurse practitioner with more than 15 years of experience in adverse childhood experiences and trauma-informed care. We also have Dr. Deborah Rose, who is also with Health Management Associates, and she's a clinical psychologist with 20 years of experience in behavioral health services, including assisted outpatient services, and she is certified in diversity, equity, and inclusion, and has experience working with social services agencies. We're also pleased to be joined by our partner, Rachel Chambers, who is the co-executive director and COO of Painted Brain, which provides peer-based services and training and clinical mental health services. So let's take a look at our agenda today and preview some of the content. So we have 4 sections. Dr. Hill and Rachel will take us through the first few sections, an overview of bias, and then walking us through different strategies that can be taken both at the individual level and then at the organizational level to address or manage bias. And then Dr. Rose will take us through how we can apply those concepts of mitigating bias through the lens of different roles in the care process. So let's take a look at our learning objectives today. Our goal is that by the end of the session, participants will have an increased ability to do a couple of things. One is describe the impact that biases can have on ourselves and others. And the second is list some action steps that an individual or an organization can take to manage bias.
Hi there. We have an important update regarding the CARE Act beginning January 1st, 2026. Changes made by Senate Bill 27 will go into effect. These changes include bipolar 1 disorder with psychotic features will now be included as an eligible diagnosis under the CARE Act, except psychosis related solely to intoxication. This law now defines what it means to be clinically stabilized and ongoing voluntary treatment. Certain court referrals can now serve as a care petition. Criminal courts may consider care referrals earlier for individuals found incompetent to stand trial in misdemeanor cases. Nurse practitioners and physician's assistants are now authorized to complete affidavits in support of care petitions, and there are also some technical amendments to streamline the care process. Our training PDFs, including the notes, have been updated to reflect these changes, including the addition of bipolar 1 disorder with psychotic features, and they are available on the CARE Act Resource Center. But during this training video, you may hear older references to schizophrenia and other psychotic disorders, so keep this update in mind that it will now include bipolar 1 disorder with psychotic features starting January 1st, 2026, and other updates made by Senate Bill 27. Thank you for staying informed, and please review the updated resources linked in your training materials. You can find more information about these changes in our SB 27 brief on the CARE Act Resource Center, or email us at info@careact.org.
So with that, I'm going to turn the time over to Dr. Hill to get us started. Dr. Hill?
Well, thank you so much, Patricia, and good morning, everyone. Let's just have a little bit of an overview. It's always really nice so that everybody is clear on how we're defining bias and implicit bias. So a bias is a tendency or an inclination or a prejudgment toward or against something or someone, an idea, a group, anything. You could even have a bias against food or weather, all of those kinds of things. But biases are often based on stereotypes rather than actual knowledge of the thing. Now, not of food, But sometimes, you might have kids that say, I won't eat anything green. They're biased against green. So it can be something that's really not founded, right? Based on life experience and influenced by messages we've even been given by people in our lives, family, friends, teachers, social norms, cultural norms, media, social media, other things, can be a different type of bias, which is an implicit bias. Our brains place people in groups based on outward appearances and stereotypes down in the amygdala of our brain. That was actually back sort of in the caveman days, a thing that protected us. If you saw something that was unfamiliar to you or that was different than your group, you wanted to know whether or not they were safe or not. And so that's really where many biases come from, is from a place of safety, in addition to the messages that we get from all of those places that I've just talked about. What's important to know is that stereotypes are not correct, as I've said earlier, but influence our thinking and our perception of others and of ideas and places. It's not always about potential harm, although safety is often sometimes the purpose, at least initially. We can take it to an extreme. And so this is why we're going to talk a bit more about this today. And we always like to, my colleague and I like to start these off with an exemplar. And so I'm going to pass it to Rochelle to give us the exemplar for our talk today.
Thank you. Before we jump into our discussion, we want to, on implicit bias, we want to introduce you to Frank. Frank is a fictional case for us to consider as we discuss implicit bias and the CARE Act. He is not real, but his situation may sound familiar to you. As we talk today about how implicit bias can impact individuals going through the care process and strategies that we can take to reduce barriers, think about how these concepts could impact Frank. Frank, he's a 68-year-old single man, immigrant from Dominican Republic, formerly military, living with schizophrenia and PTSD, post-traumatic stress, and has a history of trauma. Frank is currently unhoused and intermittently stays in shelters and often hears voices and makes a scene in public, and has ended him with multiple arrests. Increasingly, Frank is paranoid regarding authority figures, and those situations have intensified with law enforcement. Some of the things that Frank enjoys is classical music and attending Catholic Mass when he's able. Frank has a sister that he stayed with time to time, and she helps him out with money when she's able. His homeless outreach worker filed a petition for care court, and Frank has been found eligible to meet the criteria. Now I'll turn it back over to Karen to give us an overview of Frank and how his experiences and implicit bias can impact CARE Act.
Thank you so much, Rochelle. I talked a little bit about implicit bias, but we're going to talk a little bit deeper about it now. One of the things my colleague and I both want to make it clear is that as human beings, we all have biases. They're normal. And so the goal really for us today, the big take-home point is that we have to be aware of our biases, be self-reflective of them, and make sure that they are truly founded and that they're not, and decide whether they are or not, weigh those kinds of things, push them to aside if they're not, because they're never probably going to go away. They're always going to creep up at different times in our lives, and make sure it does not interfere with our care of our care recipients. That's really the important thing. Biases is a form of human functioning. It's one form of bias, implicit bias, is it happens unconsciously. For example, if I move to a new neighborhood and I don't know anybody in that neighborhood, and everybody looks foreign, and then I see somebody who looks like me, I may have a tendency to gravitate to that person because I feel more comfortable around them. They remind me of something that perhaps was familiar or safe to me in the past, right? Rather than go to a stranger and ask a question about that. So we're hardwired to have these biases. And so we have to accept that biases exist, right? And as thinking, rational human beings, we have to be very cognizant of them and reflective about them. And so we need to take actions to mitigate the negative impact of our biases, because they can, for sure, be good. There are some biases that are good. For example, if you have a bias that you like to get up every morning and stretch and exercise and have a nice, healthy breakfast, that's a good bias to have, right? That's your own personal sort of self-care things, and that's a bias that you value your health, and that's a good thing. So we're not saying every bias is bad. Let's go to the next slide and talk a little bit about how biases can impact as we do this work. As service providers, we always can have the best intentions at heart, yet our biases can get in the way through casual encounters. They can limit the services that we provide for other people, because we can make a judgment to say, oh, if we're thinking of Frank, well, he's got PTSD and he hears voices, he's certainly not going to participate in the care court process. Or you can think automatically he's going to be difficult to deal with because he can get upset in public when he's upset, or there's a flare in his mental health condition and he ends up in jail, without really looking at him clearly. It can impact our client-provider relationships. Biases can impact our relationship with our colleagues and coworkers, our hiring practices, all of those kinds of things, the kinds of clients that we deal with. Let's just say we have a bias against women or people of color, or all of those things. They can get in the way of our work. And so we have to really be mindful as we do this work of where we come from and what we're bringing to the work and the practice. Let's go to the next slide and think about and look at the different layers of discrimination. We've talked really about Frank's ethnicity, that he was a veteran, that he's an immigrant. There's these other layers, but also age. Some people have biases around people that get to be a certain age. I mean, I will speak for myself. Now that I have this gray hair, people respond to me differently, almost as if like I can't hear well or I don't understand as much, right? Sexism, racism, ableism, people who have a disability are often treated differently. Nativism, you're going to stay with your own group and that's all you want. We see a lot of that. Ethnocentrism, colorism. Perhaps you're part of a group, but maybe you're too dark for that group, or you're too light for the group. Maybe you're too big. We see a lot of this in the news around airplanes and different things about size and can you fit into the seat and how we think about other people. And then, of course, homophobia. This list can go on. And the thing that's interesting about this for me is that it can be layered onto one person. So Frank has several of these areas that he could experience biases because of that. Let's go to the next slide. So when we think about biases, the important and implicit bias specifically, really the biggest way for us to mitigate any of this is we've got to take it head on and look at it straight in the eye and look at ourselves. We've got to look at our world, our daily interactions, the decisions we make and why we make them and where they come from, our own types of behaviors, who we hire, the kind of services we provide, the kind of policies we develop, the kinds of people we have in our personal group. When we have social time, are we always with the same type of people, or do we invite different people into our circle of friends so that we can learn about other people? Often biases are compounded if you are really busy, if you're overworked, if you're too tired, then that's when your implicit bias can crop up and you're not as reflective about that. So we've just got to think about how we move forward. And let's go to the next slide. When we talk about looking at ourselves, right, one way to do that is to evaluate your own bias. And so we have for you the implicit association bias. You're going to all get copies of this, and you can take a test around any of these areas: religion, gender, skin tone, sexuality, weight, weapons, all kinds of areas, and see where your biases may crop up. You will be surprised. I've taken this test, and I was surprised. I thought, wow, I'm the most, I think in some ways I'm pretty liberal. And when I took the test, I was like, oh, gosh, you do have some biases. Not good or bad. It's just a reality and something that we all need to be aware of. Let's go to the next slide. So why do we want to take it? Why do we want to take a test? Is that people don't always say what's on their minds. They want to be politically correct, right? Even though that thing, that implicit bias that's working sort of in the background and unconscious, we may not even know it's operating. If you are always with the same people, or you always make the same choices with the same patient population, by taking an IAT is what it's called, it gives you some insight into your own thinking. Rachel, let's have some experience with taking an IAT. Can you talk to us a little bit about that, how that was for you, Rachel?
Yes, I actually took the test as a result of getting training. And as a leader, when I saw the menu of services, I was a little bit intimidating because, like yourself, Karen, I also saw myself as liberal, pretty free thinking, very conscious, but very much afraid to kind of uncover where my bias laid. So I just want to encourage other leaders, when you're thinking about, like, as Karen said, like, taking it head on and addressing it with yourself, like, don't be afraid, or it's okay to be afraid to know the unknown. But then, the beauty is being able to do the work. And this training is going to be able to help you individually and as an organization be able to address some of those biases, good or bad, that you uncover by taking this test. And that could potentially impact at the individual level with the care recipient, as well as your organization, in which the staff that serve our clients and our recipients as well, and how those biases and policies could impact your organization in the practice. So yeah, taking the test, just do it. And there is some fear, but you're going to grow from it, like we have, both of us.
Right.
Thank you.
I mean, you can't fix anything if you don't even know it exists, right?
Exactly.
You can't make any change if you don't know that it exists. So let's go on to the next slide here, because I think we've given you some resources. You can go right on. These are YouTubes. You'll get them. They're very short, little. Some of them are a little bit longer, but most are under 30 minutes. Some are 15 minutes. It talks about schemas and attitudes, stereotypes, real world consequences, all kinds of things. I just want to briefly share something with you, is that when I was running a clinic and I needed to hire a staff person, and I kept passing over this one application. I kept passing over, and I was interviewing, and it wasn't really the right one. And finally, A trusted colleague of mine said, Karen, why don't you interview this woman? And the reason I was looking over it, I'm embarrassed to say, is I couldn't pronounce her name. So yes, we even have name biases, right? A name bias. I couldn't pronounce her name, and I had all these ideas of who that person was going to be. Long story short, I interviewed her, hired her, best hire I ever had, worked for me for 15 years, is now a director and a manager at another healthcare organization. So see what you learn there when you do that, when you step into, and sometimes it takes other people to say, hey, why ask you that question? So let's go to the next slide and look a little bit about how it can show up in a different situations and experiences. I've just shared how it can be in the workforce, but it can be within our own families. People could, if we looked at Frank, his family might have a certain bias about him having a mental health problem. Perhaps they weren't happy that he went to the military. Maybe they're not happy that he still belongs in, pays attention to his faith, how he feels about law enforcement. Any of these kinds of things, they all can fit in. People have different feelings. These biases can really, really be very harmful. There could be positive biases, but there could also be negative ones. People may think that Frank is volatile, that perhaps he's not as smart, maybe his English is not as good, maybe his religiosity, or if they could make assumption about that, all different kinds of ways that this could pop in. Rachel, do you have any comments about this or anything you want to add there of how you see it?
And I think that feeds into the next slide, to just dive a little deeper into Frank's experience.
Yeah.
So just taking a deeper look to what you were saying, Karen, there can be a number of biases that show up for Frank in the care process, particularly the fact that of his age, as you noted, that could be a bias that Frank can experience, as well as his schizophrenia status and PTSD status. The care expectations for his care providers might be low because of that status and his diagnosis. He's also his faith and religion, people's perspective on that as well. So exactly what you said, like there's a number of biases that can show up because of the number of identities that Frank has. Mm-hmm. So it's important for us as providers to be aware of that, and those factors, those that can be strengths for Frank, particularly his religion. You know what I'm saying? Even his veteran status. Us as peer leaders, like we see a diagnosis and that lived experience in a way that as a means for employment and as a way to building your recovery. So these biases in the right setting and with the individuals with the right training can actually be turned into strengths. So just wanted to highlight that. And Karen, we can turn it over to you to really dig into some of the, serious mental illness, ethnicity, and kind of how that plays into implicit bias.
Thank you so much. I wanted to just touch on a point. You said the different identities that Frank has. It's that intersectionality. None of us are one thing, right? We all come with our stuff, right? So that's something that's important to think about. We have serious mental illness. There's race, there's ethnicity. Providers are often more likely to overdiagnose a serious mental illness in African American ethnic minority groups because they don't often do the work that they need to do, or they're not familiar with those groups, or they're not familiar with cultural norms or how people present. And so these are all things that are really, really important. For example, Frank is living with schizophrenia and PTSD, as we've said before. He's also from the Dominican Republic. Perhaps you may have a personal bias about the Dominican Republic or the Caribbean in some kind of way. His skin is not white, all kinds of pieces. These are all factors that could affect how he can move through the care process. And then on top of that, he's got a serious mental illness, his schizophrenia, he's got PTSD. We know that that comes from some sort of trauma. So there are many, many, many aspects of things that we have to be aware of and try to mitigate. Rachel, let's discuss this on the next slide, some ideas in action of how we can better consider and understanding bias, how we might better fulfill our role in the CARE Act with our care recipient.
Yeah, a couple of notes on how I think that us as providers can understand and help people better fulfill their role in the CARE Act is by building compassion and empathy for care recipients like Frank. You know what I'm saying? Getting to know their interests. Like, we said like he likes music. His faith is important. Like those things all I believe, getting to know those things build compassion and empathy for a person when you get to know them. And having approach each person as a unique individual. Don't categorize them like, all those people are like this. Like, figure out what is unique to Frank. Like, as we noted, like, don't categorize all people from the Dominican one way. And like you said, figure out their strengths. Make no assumptions. For example, don't make any assumptions about Frank's background. Particularly like even when someone's from the same culture, they can still have different practices. I know when I was younger, and this is since Karen told a little tidbit about their bias. When I was younger in high school, I had a friend that I didn't understand, why they had been passing, their Spanish class, and they had been afraid to tell me that they were Afro Latin and spoke, Spanish. And I believe it was because of, the environment, the high school. I don't think many of us understood that, African of descent individuals, spoke Spanish. And so that was just like, woke me up to a whole other identity and the duality. And so understanding and getting to know and not just letting your biases when you see people is really important as a practitioner, and not imposing your culture. And my experience, like I grew up in a very religious background. Some people might not have. Those are things that are unique to me. Try to understand that other individuals' culture, practices, religion, so that you can better understand them. I know, Karen, I don't know if you have any other things that kind of, went deep on.
I think you absolutely hit it. I think that we can mitigate bias if we pay attention to ourselves and if we are open and use a trauma-informed approach to looking and trying to learn about others, right? It makes our own lives richer. Let's go to the next slide and look at some of those strategies for addressing. We know that we have to look at it at the individual level and also at the organizational level. And I'm going to talk about the individual level right now. Let's go to the next slide. So we've talked a lot about this. Be introspective and curious about your own biases. Take a test. Look at the kinds of choices that you're making. Be aware of how your own bias may affect what you are offering or doing and saying to the folks that you're working with in your environment. Not only your care member, but also the CBOs that you interact with, the people that in your job that you're interacting, because biases can get in the way of all of that. Be willing to practice those principles of trauma-informed care, trustworthiness, making sure that you promise on your delivery, that you're non-judgmental, that you're using your active listening and really listening and trying to hear and understand, and be informed about people who are living with the experience of schizophrenia and of coming from places that are different than you are. That's really one of the big important points. And before I pass it over to my colleague, Rachel, I want to say that it is an iterative process. You have to constantly continue to reevaluate and look at what you're doing and why you're doing it. Let's go to the next slide and as we talk a little bit more about this, right? So I've said, take that implicit bias test, take more than once, take it one test, check other areas out so that you can see. You will surprise yourself. You might be pleasantly surprised, and then you might scratch your head and say, oh, I've got to do some work here. Broaden your images of what success looks like. I gave a situation that really happened to me where a trusted colleague had to bring it to my attention that I was being biased against somebody who had a name that I couldn't pronounce and came from a culture that I didn't really understand. We want to resist that temptation to be defensive. We want to risk that temptation to think that we know already what something's going to be, because remember what we said in the beginning, many of our stereotypes and our prejudgments are incorrect. Being able to have a trusted colleague depends on the education and training. And so some of that is work that our organizations will need to do, but we'll hear more about that next. Let's go to the next slide. So we want to take that whole person approach and come up with some action steps. Seek out the strengths of our clients, right? Some of the things that you may think about an individual could be true, but they could also be a strength. And how can we turn something into a strength so it's being seen as a strength? Find out ways to put individuals at ease. I've said list our active listening skills and try not to sort of interrupt. Those are the things that help with our biases. People will teach us how to work with them and how to better understand them if we show a genuine desire to really want to learn instead of trying to tell them what's wrong with them all the time and to hear their story. Avoid using a power dynamic over someone. Sort of try to adopt a supportive and decision-making approach. Remember, the CARE Act is really person-centered, and them bringing their entire complex, multi-layered selves. And we are working with those people to help them to optimize their health and wellness. Those are really the important points of action and interaction that make an absolute difference in this work. Let's go to the next slide. So learn about cultural background and life expectations, and that's more than just picking up a book. It's great to pick up a book, but as Rachel said to us, is that we're not all alike from one culture. Every member that you meet from the Dominican Republic is not going to have the same worldview. So that's why it's important to talk to people and get to know people, expand your own horizons. You will be pleasantly surprised. Also, it's an opportunity for us to deepen and expand our empathy and compassion and respect for people who've had different experiences than us. I love this saying, and I want us to remember it because we've had other talks about trauma-informed care. It's not what's wrong with you. It's what happened. Oftentimes, the people that we work with will have behaviors that could be quite upsetting to us. And so the question we should ask ourselves is, I wonder what happened. You can ask them, what happened to you? And get folks to tell you about their honest and true experiences. And that gives us sort of a window into their own lives. Next slide. We want to pay attention that we educate ourselves, right? That we don't go on rumor and sort of community gossip about what schizophrenia is and why you get it and other psychiatric disorders. Education is really, really powerful. And it's powerful, and it's important, particularly if we are working with people with serious mental health issues, that we know what some of those are and what they look like and why people sometimes behave the way they behave or the way it's demonstrated in their worlds, right? Be aware of the media that you consume, how much of it you consume, because some of that stuff is really poison and can bias us and reinforce our own negative biases. If you've looked at anything, whether it be on Instagram, TikTok, social media, even some news, and some of the things that come out of there is just like, whoa, really, really hard to listen to. So be mindful of that. It's okay to turn that off sometimes if it's negative and upsetting and not going to be helpful for anyone. And then finally, we want to allow for different models of support and recovery. There are many ways to get something done. It's not my way or the highway. And that's why this is important, that as we build our plans of care, as we will participate in the care court process, that we center our client to find out what they need and want for their healing. Let's go on to the next slide. And I'm going to pass that over to Rachel, and I can talk about some of these ideas in action. I've said my piece here. Rachel, what do you think about some of these ideas in action? Do you want to add some pieces here?
Yeah, so like essentially we've been discussing strategies to, manage biases that can be taken at the individual level, like you said, right? Before we move on to strategies at the organizational level, like you said, let's reflect a little bit on Frank's situation and kind of go over some of the individual strategies that the provider can do. Let's imagine Frank's case manager, Maria, right? She works with a behavioral health organization, has been assigned to work with Frank. Maria is not new to behavioral health, but hasn't been working with this specific population, and realizes she has some implicit biases and assumptions about Frank. And I think to your point of what you were saying, like, of course, being introspective and curious about our own bias, writing those down, getting with a trusted member of your team and being able to discuss those things, as you noted, being aware immediately at like the point of service and interaction, like how you look at them, making sure your body language is, your facial expressions. I tend to be a very, expressive person. So it's really important for me. It might show up. So you could seek out a different additional information about the recipient to identify their strengths, as we talked about. Like they potentially like classical music, religion might be a strength. And putting Frank at ease by utilizing those things that Frank likes, like music, maybe talking about Frank's culture in the Dominican Republic. I think those are ways in which we can really, at the individual level, really be able to kind of break down those barriers and kind of just more, you can chime in, but just having practicing cultural humility, being curious, like you said, about individuals. And like you noted, like making sure you're informed about individuals with schizophrenia and not, showing up with your preconceived notions about what you saw on TV or what your family members have said, and really seeking out different models. And that's what I do as a leader, really trying to find innovative models and strategies that are focused and grounded in recovery for particularly individuals with a diagnosis of schizophrenia. And I believe that there's so many emerging things and so much research out there that can support you and, really understanding the population. I don't know if, Karen, you had anything else before we dive into strategies for the organization.
The only thing I was going to add is that remember what we said earlier on, that some of these biases rear their ugly heads, the negative ones, when we are moving too fast, when we're trying to do too much, when we're stressed in our own lives, when we're stressed, something's happened that doesn't have anything to do with Frank or Maria or anybody else, something's gone awry at home. And so one of the things I would suggest that can help to mitigate biases and implicit bias is just to slow down for a minute and ask yourself this question: what's really happening? Why is Frank or Maria or whoever it is really triggering me at this moment? What's really happening? Am I making the best decision? And think through these steps of what could possibly be going on. And that's it. Let's hear about some strategies for addressing organizational level, Rachel. Thanks.
I just had to just reinforce that. That is so real. Slowing down. Just remembering myself as a young provider and just all over the place and trying to show up for someone. That's a lot. So I just really resonating with me on that about us slowing down, and figuring out where that comes from. So yeah, can we go to the next slide to discuss the strategies for addressing biases at the organizational level? We can go to the next slide. But this is important because, as Karen talked about, at the individual level, about strategies, of course. Now let's discuss, ways in which organizations can manage bias. And again, as we go through these ideas, let's think about how you can start, stop, and continue doing things to manage those biases. But some of the things that organizations, like broad concepts that organizations can really take a look at when managing biases, is really promoting a culture of learning, a culture of curiosity. You know what I'm saying? Like, promoting trainings that really get folks interested in learning and excited about the work that they're doing and about the population in which they serve. Really building a workforce that's welcoming and inclusive is also important. But yes, I was just going over the high level points and examining policies and building a team with perspectives. So now we'll go dig into all those 4 concepts right now in detail, particularly promoting a culture of learning. As we talked about, organizations must have a structure and systems to promote a culture of learning, as you know, that really creates learning and acceptance. In addition to providing trainings, education, it's really important to consider, encourage your staff to learn about each other, to get curious. But of course, it's important to support education. That includes ensuring that training that's provided with the organization is accessible to all staff. Provide training opportunities for staff to extend that's external, that teaches them about concepts about individuals with lived experience, with individuals with different diagnoses, and provide incentives for your staff that are seeking education. I know us as providers, we love CEUs. So really being able to look at trainings that can really provide incentives for your staff is really important. And I think that will really promote a culture of learning and expertise. And as Karen was mentioning, really encourage your staff to learn from each other, including your colleagues and clients. Like, staff have a lot to learn from each other and from the people that we serve. That's what we believe as peers with lived experience. And we have to ensure that our staff are well positioned to engage in those opportunities and really have that environment where folks can feel safe. So by providing and creating environments where staff can share and modeling that is really important. And being able to model a space where feedback across the organization is disseminated is important, because if you're doing it at the macro level, I believe that can go at the individual level when you promote that kind of behavior. And also, leaders must model the behavior. Like I was saying, if we as leaders create an environment, create opportunities, learning hubs, sessions for staff to just dialogue, brown bag lunches where folks can just talk, I believe that those are and engage. The leaders show up for those meetings. That's important. So really consider how you're promoting a culture of learning is important. Will really support the staff in being able to really head on address those biases at the micro level. And now we'll go to a little bit into depth about building a welcoming environment that's inclusive. As we noted, it's really important to foster the practice of cultural humility. So it's not just, hiring people that from different backgrounds. It's providing resources that broaden our understanding of different cultures and different communities that our organization serves. We can have those communities and have those communities show up in spaces and give input on best to how to serve them, as opposed for us just putting our thoughts and practices on a specific culture. And do not, so another thing that we think is really important in building a welcoming environment is don't place pressure on individuals to speak for a whole group. I know that when I show up in spaces, as a Black woman, I'm always nervous. Like, I hope I'm not the spokesperson today. But it's really important to really gain unique experiences from, every individual, even if they're of the same race and background, because their experiences are unique and different. And once again, encouraging staff to share their experience without requiring them to be the spokesperson for that group is really important. So I really want to just hone in on that. And you could do that, and sometimes you have the best intention because you want to include individuals, but it could really put pressure on individuals and disrupt traditional power relationships and models that of bias. Particularly intentionally empower frontline staff to weigh in on policies and procedures. I really believe that's important when you're creating a culture that's inclusive, so that because they're on the front line, they know what's important. They're speaking to the clients. If this is really informed work, and we really believe that recovery is possible, it's going to be done through the individuals on the front line that are working with our most vulnerable populations. And like we mentioned again, just creating venues that really support feedback and disclose the steps that the organization is taking. I believe that that's really important, particularly for myself and individuals that lead organizations. Being transparent with your staff, talking to them. If your leadership is going to implicit bias trainings and doing workshops and getting mentoring, I believe that or you have a diversity and inclusion and equity plan, being able to be able to highlight that to the staff really would promote an environment that's inclusive and welcoming for people to, really share their experiences. And now we want to examine policies, and I'll have, when we get into some specific examples, I'd like Karen to weigh in. But, me being a policy individual, it's really important to continue to dismantle existing structures to promote that promote biases. Organizations will really need to look at really those core policies and procedures that they're operating. For example, organizations whose policies and procedures do not protect certain minority groups will inherently bolster biases towards those groups. So that's really important. So leadership can once again invite staff to share their ideas on this work. But just so that we can go a little bit deep, I'd like Karen to really give us a couple examples of those policies and procedures that can really support with addressing biases.
Okay, I'm going to give you some examples in my own clinic. We know that sometimes some of our clients can be disorganized and maybe not make appointments on time. And so we had a very rigid rule about coming to your appointment. If you were 10 minutes late, the rule was you had to reschedule, and it might not be for the very next week. Well, that's really a bias against somebody who might not be housed, who might not be thinking as clearly as they could on some days, might be standing in line trying to get breakfast. So we had to change that policy. And so we gave a little bit more leeway, and we also had a drop-in time so that if somebody couldn't make their appointment, they could come into either the drop-in hours in the morning and the drop-in hours in the afternoon. We had another situation at another organization that I worked for that we had a pretty significant Native American population. And so we had all these rules about tobacco and no smoking and all of these other things. And then when the nation came to the organization, this was at the University of California, and talked about how important tobacco and sort of the smoke was, that we made some allowances so that they could still practice their religious practices, and still, so it was a win-win. But what it took was conversation, listening, hearing, and empathy, and a willingness to make change. And so I think that those are some opportunities. It's not always around race and ethnicity. Sometimes it's about the things that make our lives easier. For example, do we have Saturday morning hours for visits? Are we doing evening hours for some of our to make appointments and things like that? Is there a way we can work with some of the courts to make it so that our clients can participate more? Let's go to the next slide.
Thank you. So I think that plays into those policies and procedures, really plays into the next slide about building teams that really that bring a variety of perspectives to promote those policies that you were speaking to, Karen. And to the major points that we want to highlight, and I believe this is really key. In addition to improving your hiring practices and promotion practice, fostering an effective foster an environment where there's effective staff with diverse voices is important. As we noted, you have to create an environment where staff from diverse groups feel that their perspective can be heard and shared, as well as ensuring that leadership and management are welcoming to individuals from diverse groups. So it's really important that when we're thinking about hiring practices and promoting people, we first got to make sure that individuals from diverse groups and backgrounds, voices are being highlighted in their perspectives, because that can also inform our hiring practices. And then incorporate, the biggest thing as well is to incorporate diversity and equity and inclusion practices into our hiring and promotion. Actively seek to bring in on new staff with diverse perspectives and backgrounds, as well as promote existing staff with diverse perspectives and backgrounds. And I believe that that's important, particularly me as I run an agency, because we say we do what we say and we reflect the community. So we really serve individuals with disabilities. So it's important for us to hire individuals with disabilities. And that can be various disabilities. That can be with mental health disabilities. That can be with a physical disability. That can be individuals from different genders and sexuality, different races and backgrounds. But it's really important, if you say that you really are culturally competent and doing this work, really your staff should reflect the diverse backgrounds and religions and practices of the people that you serve. So really some steps that you could take is really identifying partners. If you don't have the capacity within your current agency, look for other partners to create pipelines, create scholarship programs and advancement programs to promote various groups to engage in your career. Also provide inclusive benefits and flexible practices to attract a variety of candidates. Flexible work schedules really are important for different individuals, and also promote a holistic requirements for promotion, really realistic, like promoting, having an environment where people work 80 hours a week, and that's the expectation for promotion is really, unrealistic. So really being able to have holistic approach to while you're doing this. So we want to kind of wrap up this concept in the next slide, and I'll have Karen kind of weigh in on some ideas and action on these whole concepts of promoting a culture of learning, Karen, building a welcome and inclusive environment, really examining, the policies that you said and practices that you put in place at the internally and externally, so that they're inclusive and don't reinforce biases. And as we wrapped it up, putting that team together. So I don't know if you want to add anything to that.
The only thing I want to add to that is having an open dialogue. I think if we were to put these actions into place, including our care recipient, our petitioner, the volunteer supporters, the agencies that we interact with, the court, speaking up, I think this is really, we'd be far along the road and tapping all of that with education. Let's go to the next slide.
Thank you. And I want to thank Rachel and Karen and Patricia for including me in this really important discussion. And we've heard a lot about managing implicit bias as an individual, as an organization. And what I'd like to do is talk a little bit about how we can implement those thoughts into the CARE Act, the CARE process, the CARE plan. Next slide, please. There are a number of roles that are involved, and that means that there are a number of opportunities to consider implicit bias and how we work with recipients and with respondents who are involved in the CARE plan. Let's take a look at some of those. On the left side of our screen, we have what we're thinking of as best practices, things that can be done, thoughts that can be considered both at an individual level and at an organizational level when we address managing implicit bias. And those, because they're best practices, we're keeping them on each slide to draw your attention to how they apply to the various roles, the various settings, and the multiple people who are involved in the CARE plan process. We've talked about these strategies, and so let's think a little bit about how they apply to some of the specific individuals. Certainly with the client or the respondent, people live with our own stigma about our own illnesses, and we have opportunities to help individuals who are living with serious mental illnesses address and consider their own stigma against medication, about seeking treatment, about asking for support. And one way that we can address that implicit bias is to really encourage individuals through psychoeducation, through non-judgmental support, and through meaningful ways to help individuals recognize that mental illness, in this case schizophrenia and other schizophrenic spectrum disorders, are diseases like diabetes or like cancer. They're not something that is elected. They're not something that happens because you've done something wrong. And so addressing some of the stigma, the internal stigma, I think is an important aspect of how we can consider addressing implicit bias. It's certainly for the petitioner, there are many opportunities that we can address some of these issues. Again, psychoeducation is a great opportunity. Psychoeducation meaning that we are teaching strategies, we're teaching information, we're providing recovery opportunities and explaining what those look like in a very tailored and specific approach to people. And so there is an opportunity to help people who are both petitioners and thinking of bringing a petition forward to address implicit bias about what it means to have a family member or a friend or a loved one living with a serious mental illness. I think that we can also help address some of our own biases by broadening the knowledge and the understanding of what recovery looks like. And that recovery is really different for each person. It's a pathway that one follows, and there's going to be ups and downs and hurdles and successes. And so recognizing that not every person who is living with schizophrenia looks the same. And certainly people who are living with schizophrenia might not look like what we see on TV or what we see in movies, and sort of recognize that each person is unique, and that opportunity to help educate petitioners who are bringing these petitions forward in the CARE court. And then the volunteer supporter, a very important role, whether it is a family member, a loved one, a person with lived experience. Again, I think that we have the opportunity to provide psychoeducation about living with mental illness, provide education about supportive decision-making so that people understand and recipients' wishes, desires, rights, preferences to what kind of services are offered and what kinds of services are received. And then again, helping folks to recognize the strengths of the people that we're serving. These are folks who aren't just living with an illness. These are also people who have joys and hopes. In Frank's case, he loves classical music and he's connected to his church. And so some of that training and some of that education about addressing implicit bias is to recognize more than just the diagnosis, but to recognize the strengths that each person offers. Some additional things, and I appreciate that Karen talked about active listening earlier, is really thinking about and learning how to work with individuals while we withhold judgment, making eye contact, avoiding facial responses, and being genuine to hear the individual as a unique person. So I think that those are a few opportunities to manage implicit bias at an individual level. Why don't we take a look at the next slide, please? Thank you. My colleagues have talked a bit about how we can manage implicit bias at an organizational level, and I really appreciated hearing about specific policies. I think that we have some opportunities in behavioral health to apply some of those principles. Certainly, Karen gave examples of the names of people who are applying for jobs. We can consider redacting the names off of resumes when we look at them. We can train, we're doing a lot of Zoom interviews with staff, and so we can train our hiring managers on recognizing that not everybody has a private office that they can interview from. And there may be things in the background, or you might hear noises in the background. And so to recognize the differences that people have as they are interviewing. We talked a little bit about ageism, and I think it's not just about considering what it means to hire or to work with somebody who has more experience in their career, but also people who are newer in the career and what they can contribute to serving recipients in the CARE Act. We've talked about doing some implicit bias testing, and that can be encouraged at an organizational level. That certainly can be brought into training and a commitment to diversity, equity, and inclusion and belonging training throughout the agency. I think that certainly how we consider supporting individuals who are living with serious mental illness, approaching each person with empathy, with compassion, putting aside our own biases and to genuinely connect with the individual. From an agency level, helping people feel comforted and welcomed. Do we have artwork that reflects what people look like? Do we have reading material in multiple languages? Things that address that we recognize the uniqueness and the diversity of those that we're serving. So again, some of the best practices that we've identified. So take a moment and think about how your team may be able to apply some of these approaches. Let's go to the next slide, please. I think that housing and community support providers are very much like behavioral health agencies in the sense that the best practices for working with individuals who are living with schizophrenia and other schizophrenic disorders, those same best practices apply to leadership organizations, to regulatory organizations, and to direct service providers. And so we think about the different ways that providers who are working with recipients who have a care plan or a CARE Act, we can apply those same principles that we're talking about, including turning to clients as experts in their own care. What's important to the individual? What are their preferences? What kinds of religious events matter to them? If somebody is fasting because that's part of their spiritual and religious identity, do we recognize that and tailor our services or our hours or interventions to meet the needs of that person? So really matching services to the individual. I think it's really essential that we consider our own biases when we're working with the care participants and supporting our staff to recognize theirs as well. And again, creating a warm environment with reading material, with artwork that reflects it, with staff who look and sound and speak like the care recipients that we're serving. Why don't we go to the next slide, please? Thank you. This is a big one, the courts. What can the courts do to manage implicit bias and to address that? And certainly there's lots of opportunities, and we have heard and we welcome and we support and encourage courts who are approaching interactions with potential respondents in unique and different ways. In some cases, judges are electing not to wear the black robe. And there still is the black robe effect that occurs, but they don't have to necessarily be wearing it. They carry the authority, and some of them are choosing to offset some of those inequities in the balance of power by not wearing a black robe. Some of the courts are holding events in informal settings, in conference rooms, around round tables instead of in formal courtrooms. These are some of the ways that the courts can support and address implicit bias. Certainly by being informed about what it looks like to work with a care respondent, a care participant, to receive education and understand again that each of those individuals that you are working with are unique, have their own strengths, have their own preferences, and to consider opportunities to build inclusive models to serve those individuals. Next slide, please. So as we take the really valuable information that has been shared in the last hour through my colleagues, I would like to encourage you to take a moment and think about how you would put these ideas into action. What might you have learned that will encourage you to stop or to pause and to consider something that you're doing? Maybe it's something as simple as sometimes we make assumptions that all English speakers read English, or all speakers of other languages read in that other language. Not necessarily true. Maybe we want to ask people what's their preferred reading material. So what's something that you might stop, reconsider, and think about doing differently? What have you learned today that you might start doing? We've talked about taking a test. Perhaps that's something you'd like to consider for yourself or encourage your staff to consider. And then what's working really well? And that's, I think, a moment that you can connect with your colleagues and say, what are we doing that's been impactful, that's been helpful, and that's made a difference? What's worked in other communities? So what's something that you might continue to do? And so with that, I want to thank you, and I'm going to turn it back to my colleague, Patricia.
Thank you, Deborah, and thank you, Dr. Hill and Rachel as well, for sharing your expertise, what this has looked like in practice, in all of your different experiences. So again, some of the objectives that we had for today's session describe the impact that biases can have on ourselves and others, while at the same time recognizing we all have implicit bias. We've talked a lot about different strategies, and one of the objectives is that you can list action steps that an individual or an organization can take to manage bias. And Dr. Rose just walked us through the thought of experiment of what could you stop doing, what could you start doing, or what could you continue doing to continue managing and addressing implicit bias and the support and care that we provide for others. So we just wanted to highlight a few next steps that you could take after this session. So all of our training materials are on our CARE Act Resource Center, including recordings of past trainings. We mentioned several of the trainings in our trauma-informed care series, which are listed on the screen. Karen referenced trauma-informed care as a way to approach individuals with humility and compassion, and addressing implicit bias is a crucial component to trauma-informed care. So you can find those trainings along with our other resources and trainings on the CARE Act website. And highlight a few additional resources for you. We have some implicit bias videos from the UCLA Office of Equity, Diversity, and Inclusion. We also have some courses by the National Institutes of Health, and you can view some of those training materials, and also that implicit bias test, which we reference out of Harvard, to test some of your own assumptions and to see where you might have implicit biases that you can make note of and work to manage. We also, on the next slide, we'll share our email address. There's no wrong door. So you can go to our website to find more information. There's also requests for technical assistance. But like I mentioned, there is no wrong door, and you can always send us an email at CARE Act, info@careact.org. And we may not have the answer, but we can try to connect you with somebody who does have the answer or who can connect you to resources. So thanks again for attending, and please let us know if you have questions.